Next is Dr. Martin Blakely, who's a pediatric general and thoracic surgeon and who's had a career-long interest in comparative effectiveness clinical trials in neonatal surgery. He's currently a professor of surgery and pediatrics and the program director of the Center for Clinical Research and Evidence-Based Medicine at the University of Texas Health Science Center in Houston, Texas, after a long period at Vanderbilt University Medical Center and University of Tennessee Health Science Center prior to that. He started his academic career with an NICHD K-23 Mentored Career Development Award with Dr. John Tyson, neonatologist and noted clinical trialist, as his primary mentor. He's conducted multiple randomized clinical trials addressing important neonatal surgery questions, as well as trials addressing other pediatric surgery issues. He's acquired multiple R01 and other large grants from NICHD, NHLBI, NCATS, and most recently AHRQ. Two notable RCTs are the necrotizing enterocolitis surgery trial and the HIP trial, which we will discuss today. Recently, he has pivoted towards implementation science out of concern that clinical trial findings and recommendations all too often aren't implemented clinically as much as is needed. All the clinical trials he is working on currently include some attention to implementation considerations of the therapies or programs under investigation. Welcome, Dr. Blakely. Thanks. And last, I'd like to introduce our trainee presenter today, Dr. Nikitha Gorti from Children's Hospital at Montefiore, who is here to present to us on the effect of early versus late hernia repair. I'll turn it over to you.
All right, thank you, everyone. So yes, thank you for the opportunity to present today. So the article I'm presenting is effect of early versus late inguinal hernia repair on serious adverse event rates in preterm infants. The authors are the HIP investigators, with the PI being Dr. Martin Blakely, who's here with us. It was originally published in JAMA in March 2024. So as I review the article, I'll be going through the CONSORT checklist for reporting a randomized control trial. So as I go through this, I'll highlight the checklist items which are included in the article. So to begin, I will talk about the reason why inguinal hernias occur. So testicular descent involves two phases, intra-abdominal and extra-abdominal. Testicular descent during the extra-abdominal phase of testicular descent, which is around 25 to 35 weeks of gestation, the testes descends through the inguinal canal, drawing with it an extension of the peritoneal lining called the processus vaginalis. The processus vaginalis obliterates generally between the 36th and 48th week of gestation. Or when neonates are born less than 36 weeks gestation, the processus vaginalis tends to remain open, resulting in a higher incidence of inguinal hernia in premature neonates rather than full-term infants. The incidence of inguinal hernias is approximately 1 to 5% in term infants. Among preterm infants, the incidence is higher and is reported to be as high as 20%. The risk of incarceration in infants is 8%. A study by Lotz et al. Demonstrated that the rate of inguinal hernia incarceration in 49,000 premature infants reviewed was 16%, with a proportional rise in the rate of incarceration with increased age at the time of surgery. Inguinal hernia repair is the most performed surgery in premature infants. It is considered the standard and required treatment for infants with inguinal hernia. Per the American Academy of Pediatrics, there is significant variability in practice, from 3 to 74% of centers performing the surgery upon discharge. With early repair, there is a concern for anesthesia and cardiorespiratory adverse effects, and with late repair, there's concern for hernia-related adverse effects. A recent meta-analysis done in 2022, including 7 retrospective cohort studies with a total of 2,024 patients, recommended hernia repair after NICU discharge due to decreased risk of recurrent and respiratory complications without increasing the risk of incarceration or reoperation. So the AAP highlighted a need for a multi-center randomized control trial to compare treatment options for preterm infants. Dr. Blakely previously performed a small pilot study or feasibility study addressing the timing of inguinal hernia repair in premature infants. Early inguinal hernia repair was compared to late hernia repair at a postmenstrual age of 55 weeks. 39 of 50 eligible infants at 4 participating sites were randomized. The conclusions were that there was a reduction in serious adverse events and hospital stay with late inguinal hernia repair. The serious adverse events were only measured in the post-operative hospital days and not the entire study period. 5 infants, all from the late group, were lost to follow-up, and 4 infants in the late repair group had to have repair prior to 55 weeks post-menstrual age due to hernia incarceration. Dr. Blakely, I was wondering if you could comment on this pilot study and how it informed the randomized control trial we'll be talking about today.
Yeah, that's a good question. So a couple comments on that, especially, if most of our audience is made up of trainees, just some pearls to throw out along the way, and this is one of them. So this was a trial. This was already going on when I finished my fellowship and joined Dr. Tyson and others at the University of Texas in Houston. And I was getting my master's degree in clinical research, and we were working on the K Award. And this was a study that was sort of going on by someone else. So I became involved in it. It's one of these things where like a research resident sort of picks it up and then they roll back into clinics. And then, there I was to sort of pick this up. I mean, it was not methodologically amazing, I would say, just sort of between the family here, but it did address the most relevant question that became the question of the trial. And I think there were 4 centers. So this was really important. And, when you are preparing a grant and submitting a grant, you were trying to convince some agency or some group to give you money to do your study, and then you need to give them reassurance that you're a good investment. So along with all of the retrospective papers published, with all sort of variability, it was really nice to have this small but randomized pilot study, and it became an important part of the grant application. So that's a long answer to your main question of how did this inform the trial. It was a very important, informative paragraph in the NICHD large grant application. The teaching point here is, I presented this study at a national pediatric surgery conference. I remember getting criticized heavily. I can remember it like it was yesterday by some of the folks in the audience, because everybody sort of had their preferences and biases. But what I didn't do was I never published this. So it's one of those things that, went to the meeting, presented it, got beaten up a little bit, came back, got busy. And it's just one of those things that stayed in the filing cabinet. It's still somewhere. So, don't do that, right? It says you guys are smarter than me, and anything that's worth presenting is really going to be worth publishing somewhere. And that would have been much better and much easier for the grant application and the eventual paper, is just to have that one reference, where you don't have to kind of explain in the text why it's not published. So that's the key point there, is anything like this, even less than this, find a home for it, get it published, have it on your CV, and then use that as you're telling the story later.
Thank you. That was a lot of learning points. So moving on to the current study, we'll start with the PICO. So this was a well-designed, multi-center randomized control trial. The population is infants born less than 37 weeks gestational age who are diagnosed with an inguinal hernia by the pediatric surgeon. The intervention was early repair, defined as performed at an optimal time prior to NICU discharge, and the comparison is late hernia repair, defined as performed after NICU discharge and greater than 55 weeks post-menstrual age. The timing of 55 weeks was selected as this reflects current pediatric anesthesia guidelines to treat anesthesia-related apnea or bradycardia. The pediatric surgery team counseled the families prior to discharge on signs of inguinal hernia incarceration and scheduled an in-person follow-up visit 1 month after NICU discharge. The primary outcome was a rate of serious adverse events, which were defined as unintentional injury or complication resulting in an escalation of care, death, prolonged hospital stay, or readmission to the hospital. These infants were enrolled and randomized approximately 2 weeks from anticipated NICU discharge and were followed 10 months post-randomization. So looking at the CONSORT checklist, the title clearly defined the study as a randomized control trial, and the abstract went through the trial design, methods, results, and conclusions. The introduction stated why the study was needed, with the main objective being safety.
So, Dr. Blakely, a question for you. So how did you pick up the serious adverse events? Did you had a team of neonatologists involved in the discussion, and how were those events chosen?
Yeah, I bet we're going to get into that in the methods coming up, but so I think it is worth emphasizing that we view this as a true safety study. And there's a ton of safety literature out there, and I'm not really I didn't bring to this project like expertise in that narrow safety study lane. But in broad strokes, this is a study of doing something. So that something is hernia repair versus the choice of not doing that thing. So we viewed those two things as sort of equal. So you could make a choice to not do the hernia repair, and that comes with all sorts of possible bad things that can happen. And then equally, you can decide to do the intervention, and a whole different list of bad things can happen. And when I was designing this study, I remember a very prominent neonatologist that I'd worked with on another study saying, "Oh, please do this study. This is really needed because, I remember this baby we sent home, and, the baby died, and we all, we wondered, like, who knows if it was related, but it stuck in this person's mind for many, many years that a NICU infant with a hernia had been sent home. And I guess there had been discussion about whether the surgery should have been done. Something weeks or months later happened to this baby, and the baby died. So it left a huge impression on this neonatologist that this study needed to be addressed. So when you think about it as a pure safety study, which is really different than what we usually do with effectiveness studies, it just came down to, well, what are the bad things that can happen with either one of those choices? And we did have a lot of neonatologists on our study team. I think that's one thing we got right, is we had a lot of surgeons, we had a lot of neonatologists, and some of these studies just sort of have one or the other. So we had a whole list. I kind of pulled out the protocol just so I could be reminded of some of this stuff, but maybe 20 things on the list in the protocol of specific serious adverse events that we were looking for. And they were all defined. And then there's another category because you can't predict everything. So again, there's more detail on this than we can get into now, but that was the reason for that primary outcome being just any sort of serious adverse event. We knew that within serious adverse events, there are some you would much rather have than others, right? So that they're not meant to be equal, but the whole point of this was just to give an initial look in these randomized patients of which strategy ended up with patients having more of those things versus fewer of those things. And we can come back to that if that didn't really answer it as we go.
Sounds good. Nikitha, you can proceed.
Okay. Yeah, so now moving on to the methods. This was a parallel group multi-center randomized control trial conducted at 39 US medical centers. Enrollment started in September 2013 and follow-up ended in April 2021. At each site, there was IRB approval and written informed consent by guardians before enrollment. The study was funded by the NICHD. There was prospective recruitment with pre-specified primary and secondary outcomes. The exclusion criteria was well defined in the methods and included 1, an associated factor that impacts timing of repair, to inguinal hernia repair planned as a secondary procedure, such that the timing of repair is impacted, for example, a current GT placement. 3, known major congenital anomalies or chromosomal abnormalities, or 4, if the family is unable to return for follow-up and late hernia repair. So for both Dr. Blakely and Dr. Rysavy, I was wondering if you guys could comment on your thoughts about the exclusion criteria, especially the last one, and do you think it altered the generalizability of this study?
I mean, I'll just say it was meant to be pragmatic and very inclusive. That was our strategy. And I mean, the last one, you know, I think that is a needed criteria because of the way the study's set up. You know, if you talk to a family about this trial, one treatment arm to which they could be randomized is it would mandate that they come back and get that repair. So if the family was just purely unable to do that or unwilling to do that, then you know, it wouldn't make sense to randomize that patient in that family because they would be randomized to potentially to an arm that they couldn't carry out. So, Matt,
Mario,
if you had any thoughts.
I had a quick question for you. What does number 1 mean in practice?
Yeah, so you know, kid with major cardiac structural abnormalities and is on anticoagulation, something like that.
Sure. Yeah,
So
anticoagulation.
super
Yeah.
sick kid,
Right.
where you just can't, you know, you can't withdraw those things and, you know, do the hernia. Trying to think of some so there were some other pretty obvious things. But it was meant for that, yeah, sort of.
Yeah, that makes sense. So if you're on anticoagulants, and it's a bucket category, I think, you know, for the trainees, it's useful just to think why do we have exclusion criteria? You want studies to be generalizable. You want them to be inclusive. You know, we have a big sign in our NICU here that says every baby has a right to participate in research. So I think it's both for us as clinicians, we want to make sure that the data are generalizable, but also for the families, we think that, you know, we ought to give them that opportunity. And so we don't want to exclude anybody unnecessarily. So why do these exist? Reasons that you wouldn't want to include certain babies would be as if you didn't have equipoise. So no clinician thinks it's a great idea to go do this elective surgery while the kid, you know, is being anticoagulated. Like, we should wait on that. That makes sense. Or if you have some certain congenital anomalies, or like, why would we do this study in a baby who is going to have another procedure, like trach placement? Why would we, if that's always what we were going to do, you already were going to undergo the risks of anesthesia. The last one I think is interesting in light of both of the criteria I mentioned having to do with generalizability and inclusiveness, giving families that opportunity. And I recently had a good discussion with this with an investigator, because it is a real difficulty. You need to make sure that both for study purposes, you are able to have a family follow up and participate in the study, as well as, you know, in this case, it's literally the intervention. And so I think in this case, it's probably easier to defend than you might see in certain studies, given that if you can't come back, well, then that's not really an option for the family, right?
One thought on this too is I'm looking at the figure 1, which you're probably going to get to, but 101 of the 1,100 exclusions were due to that number 4. And I think for anyone on here that is planning a trial, I don't know if anyone on here is, but maybe I hope that's true. You know, a lot of attention needs to be placed on the accounting of these things. So I will tell you that when we submitted the paper to JAMA, I would say the most sort of active and a little bit painful process to go through was the accounting around the things we're talking about right now, because they didn't just want the answers to these 4 things, but they wanted just ultra detail. In that figure 1 that's in the paper literally took on a life of its own. So the last thing I would say, so point there is, you're obviously going to focus on the kids in your trial, but you really need to be super precise and complete in measuring that whole accounting. Approached, eligible, not eligible, if not eligible, why? And the other thing about number 4 is, again, I am really interested now, over the last year and a half, I've had this sort of branch point where it's not all about the trial anymore. It's about, what are people, like everyone on this call, going to do with the trial results? And then that starts to get at that a little bit, right? So if 104 families say, I can't come back, well, that's worth exploring, because it probably means more than, well, I just can't come back. Well, okay, why is that? And what you might get is, oh yeah, I just want the surgery done before I leave. Like, I can't come back because that's going to be summer and Johnny is in baseball and I'm not coming back. So once you start talking to different stakeholders, you then learn a lot of things about, is anyone really going to implement whichever thing is better, which is really the most important thing. So a quick thing I've learned from this trial in particular is these families become sort of professional. These aren't like naive families. These are pros that have been in the NICU for like 4 months, right? So they've had all sorts of terrible things. And the hernia is just, yeah, whatever, like, fine. Like, it's something that needs to be figured out, but it pales in comparison to some of those other things. And over that 4 months, they develop very strong preferences and ideas about what they want. So, and you want to know that, right? Like, you need to know that when you present this to people and you talk to families in your practice about it. So we know that that's a very important thing.
Okay. So continuing on the methods, the primary outcome was defined as a proportion of infants with 1 or more serious adverse event within 10 months of enrollment. The study personnel prospectively monitored for serious adverse events in that study period via EMR in contact with the family 30 days after inguinal hernia repair and 10 months after enrollment. An independent committee of pediatric surgeons and anesthesiologists blinded to treatment group assignment reviewed the case reports and made the final assessment of serious adverse event occurrence. These serious adverse events included pulmonary events, cardiac events, surgical events, events related to the hernia, and death. The secondary outcomes were the number of hospital days in the study period compared between early and late inguinal hernia repair. The other secondary outcome in the study is a rate of serious adverse events in specified subgroups, such as gestational age less than 28 weeks, bronchopulmonary dysplasia, and mode of repair. So infants were randomized 1-to-1 to either early or late inguinal hernia repair around 2 weeks prior to anticipated NICU discharge, as this was the timing when decisions are usually made regarding the timing of inguinal hernia repair in routine clinical practice. The infants were stratified by study site and gestational age strata and randomized in variable block sizes using a REDCap module that was created by the primary trial statistician. Blinding of the clinicians to the study intervention was not feasible. However, the primary outcome was determined by a committee blinded to which intervention the patient received. The primary hypothesis was that the rate of serious adverse events would be 30% in the early inguinal hernia repair group and 20% in the late hernia repair group, meaning a 10% difference in groups. To have 80% power to detect a 10% difference, a sample size of 586 infants was needed. So an enrollment of 615 infants was planned, assuming a 5% loss to follow-up. And then there was a plan for safety and efficacy analysis when there was data for approximately 200 infants. So stopping for safety if the probability of increased harm was greater than 90% for either group, and stopping for efficacy if the probability of decreased serious adverse events was greater than 95% in either group.
Dr. Rysavy, I'm hoping that you could share with some of the trainees your thoughts and kind of approach for thinking through how you're going to define primary versus secondary outcomes and provide some comments on the randomization method used here.
Sure. Yeah. First, I'll talk about the randomization. So randomization, I think everybody here knows, is critical for us to get the most unbiased estimate of the effect of the treatment, or here, the safety of the treatment. And the reason for that is if you just did this study by retrospective chart review, say, you would have all variety of reasons that one family or another, or one clinician or another, one baby or another was picked for one intervention or another. And so that becomes very confounded by all of those variety of factors. Ergo, randomization means equal allocation. It's flipping a coin, it's drawing straws, without any sort of bias in the randomization. So that's how that's intended. It's 1-to-1, which is typically what we do both for ethical reasons and for statistical reasons. It's the most efficient way. I think when you ask to describe it, you're bringing up two, what does it mean to be stratified by study site? Or GA stratum. So if you think that each site is going to have its own sort of random number sequence, that's what that means, to be stratified by site. If you go way back to the earliest neonatal trials, Bill Silverman, Dr. Silverman would make a jar with 2 different colors of marbles. So the famous ACTH study that he performed had, I think, blue and white marbles in it. And if you picked blue, say, you would give ACTH, and if you picked white, you wouldn't. Imagine that stratified means there's a different jar at each hospital, and the jar's got an equal number. Okay, so that's pretty easy. Now, GA strata is a stratification variable, so it's actually like each hospital has 2 jars. One group of babies less than 28, one group of babies greater than 28. Why do you do that? It makes a lot of sense logistically to do it by study site, besides that study site might affect, how things are. So you don't want all the babies born at Vanderbilt to have, randomization to one arm, and all the babies born at UTH to have randomization to another. That'd be imbalanced. Maybe Vanderbilt has different practices. So it makes sense to make sure that that's evenly balanced by stratification. And GA strata too. You wouldn't accidentally want all of the big babies by chance to be given, early repair, and all of the late babies to be given low repair. So this is a balancing factor to just absolutely ensure we're balanced. And like I said, logistically, you just think about it like 2 jars of marbles at each site, one for each gestational age stratum. What does permuted block mean? Well, time is one of these balancing factors. If you think about a randomization sequence, so late, early, you don't want it to accidentally in the random number generator be late for like 3 years of enrollment, and then early. That'll cause a problem. So what permuted blocks do is mean that every block of 2 or 4 is equal. So you're going to either have late, early, or, if it's a block of 4, late, early, late, early, late. We could go through all the different permutations. So that's kind of nice. And the reason it's variable like that is that you don't want the person on the receiving end to know what the next sequence is going to be. So you don't know if this is a block of 2 or a block of 4, but this is kind of a special way that you're randomizing the randomization sequence, if you think about it like that. So there's balance all across time. The other question, just really quick, was what's the deal with primary outcomes and secondary outcomes? The reason we pick primary outcomes is really twofold in the way that I think about it. One is for planning. Trials are developed to say, I need to answer this question. Does X versus Y, affect such and such outcome? And when you do that, you have to go through power calculations, et cetera. So you really need to say this trial from a planning perspective is oriented towards this. The other reason that you need to do that is even if the other outcomes are adequately powered, have you guys heard of multiple hypothesis testing? the issue of, you know, flipping a coin over and over. There's a little bit of chance here. If you do 20 coin flips, you know, one of them will probably have a p-value less than 0.05. So that's a 5% probability, 1 in 20. And so you don't want to pick too many outcomes lest you run into that. And that's beyond what we can talk about now. But having a primary outcome avoids multiple hypothesis testing. You say, this is the one, this is what I care about. Anything beyond that really needs to have some additional analysis and hopefully replication in another trial for us to believe that there's a true effect there.
One super quick comment on if you could go back a slide. This is in the spirit of presenting trials in the most optimal manner. I think we're really close to that so far. The one thing I would say is that this bottom row is not, I would not describe that as a secondary outcome. There were 2 secondary outcomes in the study. One is the number of hospital days, and one is the cognitive on the Baileys. This bottom row is looking at heterogeneity of treatment effect. So one of the appropriate knocks on randomized trials is we're comparing treatment A versus treatment B in this population. And at the end of the day, we want to run around saying, oh, hey, look, treatment A is better, right? Well, it turns out it's better for some, it's neutral for some, it's worse for some. And so that's an appropriate criticism of most randomized trials. And the sort of methodologies changing fairly recently, I think, to emphasize this point of don't do that, what I just said, where it's, an all or none thing. Like, yes, you're going to design the study, and yes, that's going to be a message, but we want there to be a more nuanced message where you've looked at important subgroups. So that is not a secondary outcome. It could be described as, I wouldn't even call it a secondary analysis. It's as important as the overall treatment effect. So that's just a pretty picky point, but I think an important one. And we may get into that a little bit later in the results.
No, thank you. That was very helpful. Just go through this. Okay, so onto the statistical analysis. So intention treat analysis was performed, included all randomized infants other than those that withdrew from the study per parental request. Bayesian and frequentist analysis were done, but Bayesian analyses were primarily used. So the advantage of Bayesian methods is that they calculate a probability of treatment benefit or harm from an intervention, combining prior knowledge and observed data. So initially there is a prior probability, which is based on prior beliefs of the probability of parameter. After observing the data, our prior beliefs about the parameter are updated using Bayes' theorem to obtain a posterior distribution. From the posterior distribution, a credible interval is derived, and that specifies the probability that the parameter lies within this interval. So in this study, neutral priors were used for all outcomes since there had never been a previous randomized controlled trial on this topic. So a prior centered at a relative risk of 1.0 was assumed with a 95 probability that the relative risk is between 0.33 to 3.0 for intervention effect. So anything above 1 favored early inguinal hernia repair, and anything less than 1 favored late inguinal hernia repair. All models were done using gestational age group as a covariate and study site as a random intercept. The primary outcome was analyzed with logistic mixed effects models, and the secondary outcome was analyzed using a negative binomial mixed model. Primary outcomes were reanalyzed for the pre-specified subgroups using Bayesian hierarchical models. Any comments on Bayesian analysis and the...
Dr. Rysavy, can you give us a brief overview for the trainees? What's a Bayesian approach and a frequentist approach, and when is one better than the other?
Yeah, sure. A frequentist just means what you all know. It's the typical system of p-values and what's called null hypothesis statistical testing. And what you're really asking there, what the p-value represents, is what the probability is, given certain assumptions about the model and how it's analyzed, that the data fit the hypothesis. So it's really asking, do the data fit my hypothesis? Usually we're using a null hypothesis, but you can derive p-values for other things. So that's what you're mostly used to. You probably were taught in your basic statistical class. And most of our tests, chi-square and t-tests and so forth, fit under that. Frequentist is only a word we use when we're differentiating that way of thinking from Bayesian thinking. Bayesian thinking goes way back. Thomas Bayes, wrote about this, well over a century ago. The basic underlying idea in Bayesian thinking is I have some preconception, I get new data. Does that modify my preconception? So that's this idea of posteriors, priors, and data. So I start with some preconception, and that's kind of an interesting thing because every frequentist analysis stands on its own. And so the Bayesians say, no, none of us actually, if you're a practicing clinician, you don't come in with a totally blank slate every time. A good example would be, imagine if you had a new study come across your desk this week that said antenatal steroids don't work in babies born at 28 and 29 weeks gestation. And we randomized 100 babies, and there was no effect on any relevant outcome of, mortality or, RDS and all the stuff that we know that antenatal steroids do. You are a practicing clinician, you would read that and say P equals, 0.10 or whatever. And are you going to take that and practice like that and just stop giving steroids at 28 and 29 weeks? Of course not, because from a wealth of other data, no, your prior, that is, hey, this worked. So whatever new data came along probably didn't push your posterior, what you really believe, to the other end to say, no, I'm just going to stop. So Bayesian analyses are neat from that angle. The other thing you'd ought to know is that Bayesian analyses actually answer a slightly different question. So so-called frequentist analysis, what you are used to is asking, does the hypothesis fit the data? And here you're flipping that around. I'm sorry, you're asking, does the data fit the hypothesis? And here you're flipping that around. So you're saying, what's the probability of the hypothesis? Like, what's the probability that this actually works? Rather than what is the probability that the data fit with the hypothesis? Somebody very succinctly, a statistician once told me, it's the difference between, is that Catholic person the Pope, or is the Pope a Catholic? And you can think about that, I think, very simply by going back and forth. Okay, those are actually two different questions. So Bayesian analyses are really to the point in that it's like, does the treatment work? What's the probability that the treatment works? And I think, Marty used this very astutely. There's been a move towards this in the field. One reason that Bayesian analyses weren't in the first trials back in the 50s and 60s, and kind of part of our base is that computationally, they're way more difficult to perform. They require far more computational resources, and it just wasn't possible. So frequentist analysis sprung up because we could actually calculate it. Now, given modern modeling and computing techniques, Bayesian analysis is really having a heyday. And you'll see it used in all sorts of technology. I mean, it's fundamental in how AI works, for example.
A quick comment
so
on
much,
this.
Dr.
I think this is really one of the most important things we can talk about. I think what we're talking about now is more important than hernia safety and outcomes and such. And I did put in the chat that there's 2 references in the paper that I would highly recommend. I was sort of struck when I looked back at the paper how few references there are. It's almost like we forgot to put some in, but these are 2 important ones. And again, I'm Matt is much more savvy about almost everything than I am, including what we're talking about right now. So, I'm just sort of a dumb surgeon. And I will tell you that the Bayesian thing should make more sense to people and should not be scary. Now, you do need a Bayesian statistician to help you generate these things. So it's not like I'm cranking this out myself. But as far as the understanding of it, I'm talking about just theoretical understanding of it. And Matt mentioned that only through Bayesian analyses can you answer the question, what is the probability that one of these treatments is safer than the other? And that's what we want to know, right? Or pick another study. What is the probability that this therapy is more effective than the other? And I would challenge you guys, because as soon as you say Bayesian, you get a ton of pushback from your colleagues, right? They're like, oh my God, this is so complicated. Like, I don't have any idea what you're talking about. You're wacky. It's crazy. And a fun sort of experiment on that, which I have put into play, it's actually not all that fun, but it turns out those people that are critical of Bayesian, they don't understand anything about frequentists. Okay. They don't understand what a p-value means. And these are good people, right? These aren't, it's not that they're bad people, but it's just that p-values have been around actually Bayesian's been around longer, but p-values have been around in our education for so long that we've dumbed it down, right? Like, people will have no idea what the p-value means. They will have no idea how complicated it is to use models and the effective models on p-values and how that can differ. No idea about those things, test statistics, all that. But what they know is, oh, if it's less than 0.05, that's good. And if it's 0.06, there's nothing to see here, right? It's almost like when you pull up to a stoplight. I have no idea how that stoplight actually works, like, the electronics or the physics or the this, that, and the other, but I know if it's green, I'm going, if it's red, I'm stopping, and if it's yellow, I'm probably speeding up to make it, right? So that's how people view statistics. And so with that limited understanding of frequentists, they then say, oh, the Bayesian stuff is so complicated. So what I started doing in conferences was when I would hear that, I would ask the room, somebody just tell me quickly, remind me what the p-value means. And it gets really awkward because no one in the room knows. And it could be a chairman, it could be, in one room recently, it was an editor of a major journal. There's, division heads, chair people, fellows, no one has any idea. And when you offer them incentive, which I've done, I'm a wine collector, and I say, hey guys, I'll give you a bottle of wine from my cellar if somebody could just tell me what the p-value means. And no one can. So just the next time you're in a conference and you hear a resident present a paper and you're looking at the graphs and they look pretty different, and they're like, oh yeah, this treatment A was not statistically significantly better than treatment B. Maybe there was a 15% risk difference, but the p-value was 0.08 or something. Just sort of, you're not going to win a lot of friends by asking people a question that they don't know, but I would tuck that away in my brain just going forward. First, everybody learn what a p-value means. It's sort of complicated. And then, just think about Bayesian being able to answer the question that you really want to know. It's what families want to know. Do you think families care about the probability of finding the data you found or something more extreme if the null hypothesis is true, right? Before you even get through with that, they're gone, right? Like, you're confused, they're confused, like nobody has any idea what you're talking about. So this is more important than the hernia stuff. And one of the references, last point, comes from the American Statistical Association. And it says, never use the phrase statistically significant again. Like, in your whole life, don't write it, don't say it, don't think it, like, don't do it. So again, I have been in this rabbit hole for a while, you can tell, but I think this is one of the most important things that can come out of this time we have together.
Great learning points regarding this. Nikita, you can proceed.
Okay. So this is figure 1 that Dr. Blakely was talking about earlier. So 1,514 infants were assessed for eligibility, and of those, 1,072 were eligible. Of those, 338 were randomized. So 734 met eligibility criteria, but they weren't randomized. And then after randomization, 18 infants withdrew and 12 infants were lost to follow-up. So as you can see, both groups had similar characteristics at baseline, including a median gestational age at birth at 26 weeks, median weight of 820 grams, percent of males, race, ethnicity. The comorbidities prior to enrollment were also similar, including bronchopulmonary dysplasia, bradycardia requiring intervention, inguinal hernia incarceration, and interventricular hemorrhage. A few more infants in the early inguinal hernia repair group had apnea requiring intervention, and the intervention ranged from stimulation to mechanical ventilation. And then when you further characterize the infants, of the 163 infants in the early inguinal hernia repair group that were randomized, 152 underwent repair at a post-menstrual age of 41 weeks, compared to the 129 out of the 157 who underwent repair at 57 weeks post-menstrual age. So the reason the early group did not undergo repair at the assigned time included clinical resolution of the hernia, change in medical condition, and transfer. The reason the late hernia group did not undergo repair at the assigned time included clinical resolution of the hernia, clinician or parent preference, and concerns for incarceration. Of note, 17 infants in the late repair group and 7 infants in the early repair group had clinical resolution of the inguinal hernia. Dr. Blakely, did you expect the rate of clinical resolution in the late repair group that you saw in this trial?
No. So in surgical training, and I'd be interested in pediatrics training, all of our training, a lot of what we learn is from the generation before us, right? So, intern learns from chief resident, who learns from attending, who learns from chair, So in surgery training, it is almost like gospel truth that once you have an inguinal hernia, that is a mechanical anatomic thing that never goes away. And maybe you don't see it because it's small or something, but the teaching that's handed down is you've got a hernia, it's like having any other bit of anatomy, it doesn't go away. It's a fixed thing. So quick answer is no. This was much higher than even if you don't believe the lore that's handed down to you, and you say, well, never in medicine's always wrong. There's always like an exception. So surely there's one that went away somewhere. So we did not expect that. It was much higher. And I think it's really important because there's a couple of important things on this slide. Is one, there's a fair number of kids in the late repair group that if that is your strategy of care and you really want to do that as your top priority, there's a reasonable number of kids that aren't going to make it to 55 weeks post-menstrual age. That just happens. Like people get concerned, even if it's not incarcerated, they're concerned about that. They're concerned for whatever reason, and it might go away. So that's important. So let me ask you guys, like, do you get taught one way or the other about an inguinal hernia? I mentioned what happened with surgeons, but like in pediatrics, does anybody ever even bring up that the hernia could go away, it won't go away, no mention?
I think it's more of it does not go away. It also depends on what center you are, where the surgeon's preference just comes down to a pediatric practice too.
Yeah.
Nikita, you can proceed.
Okay. So now moving on to the primary outcome. So among the infants that underwent repair, 308 had complete data. 28% of the infants in the early inguinal hernia repair group had at least one serious adverse event versus 18% in the late repair group. So for the posterior distribution, the absolute risk difference is negative 7.9, favoring late repair. And the estimated relative risk is 0.68 with the 95% credible interval from 0.45 to 1.01. So this means there is a 95% probability that the relative risk of at least one serious adverse event is between 0.45 to 1.01. Therefore, the probability is 97% that the late repair strategy is associated with a reduced rate of any serious adverse event compared with the early repair strategy. And then when you look closely at the serious adverse events, in both groups, the most common serious adverse event was apnea requiring increased respiratory intervention. So there was 17.6% in the early repair group versus 6% in the late repair group. The second most common serious adverse event in the early repair group was prolonged intubation versus inguinal hernia incarceration in the late inguinal hernia repair group. Inguinal hernia incarceration was broadly defined as surgical repair and bedside reduction. There were 3 infants that had cardiac arrest in the late repair group compared to 0 in the early repair group. So overall, the apneic events requiring intervention is the primary difference between both groups.
Really important on this slide is the incarceration rate. Again, you mentioned in the background, I think rates of 11 to 12, 15, 18%. And you can see here that the rate was really low. So again, I think that must come down to definition of what is an incarceration, I think mainly, and then measurement of it would be important. So I think you've talked about the chances of a hernia going away, which should be very influential, and then the incarceration rate being really low in both groups should, to me, is very influential also.
So, Dr. Rysavy, a question for you, and something we have gone through in the past papers too, about how important are each outcomes individually to be combined together. Is apnea requiring intervention same as someone who had a cardiac arrest, or is this,
Right.
for your understanding, moving towards the door, the desirability of outcome ranking, a better future approach for such trials?
Yeah, and you and maybe others here on the call probably saw there was a very nice article written up about this by the EB Neo group. It made exactly that point. We as a field, and we were talking before about statistical innovation. So, we all do the simple stats test because that's what we were taught and that's what was handed down. And that's what was possible in the 1950s based on, existing computational capacity. And now when we have the computers that we have, the iPhone I have is more technology than they had to send a man to the moon. It's in my pocket. So you can do all sorts of cool stuff, Bayesian models that require, thousands and thousands of replications. You can run it all in a minute now. We can do that. Now, another thing that we've learned, and I think this is kind of in a similar light, is how we've been handling outcomes. So really classic issue in neonatology is that you have composites. Why do you have a composite? Sometimes it's because you care about a lot of stuff. That's actually probably the best case here. You do actually care about prolonged intubation, death, anesthesia toxicity, all these bad things Marty was talking about. You have people from a big group, they got together and said, all these are things that might influence our decision. We care about them as a safety signal. And so the classic way you did this in neonatology was to put them all in one bucket and say, yes, one of these happened. No, one of these didn't happen. And that's kind of how this was analyzed. What you're referring to with regards to DOR is one of many ways to order outcomes. So instead of just having yes and no, to have all variations of different grades in between and, make a much more complex way to estimate the outcome. I think that would have been a very nice approach in this study. It's not the approach that was taken. Some of those things have become a lot more popular in the past decade, and certainly this study was started, and funded before 2013. But yeah, you bring up a great point. And for anybody who hasn't seen it, I'll put it in the chat. The EB Neo article on this is really nice. DOR is not the only way to do it. There are other ordinalized methods, but to include some sort of weighting to say apnea is not nearly as bad as death, obviously, and to try to balance these things into some outcome that means something to folks. We can do that now with modern computational power. So it's something I think you'll see more of in trials that are being published here in the next half a decade.
Thank you. Nikitha, you can wrap up the study.
Okay. So the probability that late repair reduced the number of infants with at least one serious adverse event was higher in infants with the gestational age younger than 28 weeks and in those with bronchopulmonary dysplasia with a 99% probability of benefit in each subgroup. Late repair was favored by either surgical approach method. And then in terms of the other secondary outcome, the median number of hospital days in the 10-month observation period was 19 days in the early repair group versus 16 days. And that probability was 82% that the late repair strategy was associated with lower days in the hospital. However, the percentage of readmissions to the hospital was higher in the late inguinal hernia repair group. So the interim analysis was done in February 2021 when the data was available for 308 infants, and that's the analysis that we just talked about. So they found a 97% probability of decreased rate of serious adverse event. So this crossed the pre-specified efficacy stopping threshold of 95%, so enrollment was stopped. One of the questions that I had for the group was, the trial was stopped early for reaching this threshold of benefit, which primarily consisted of apneas. What if stopping early missed any important differences in more serious adverse events, for example, cardiac arrest or death?
I'm not sure I totally got the question. Sorry. Could you?
Yeah. So the trial was stopped early for reaching a threshold of benefit, which is ethically justifiable. And it seemed that the difference was due to the apneas most of the time. But do you think stopping early might have missed some important differences of more serious adverse events since the power was less than what was originally calculated for?
I mean, I guess it's possible, but I think again, no one trial can answer all things. So I think it's the way it was set up from the beginning, with the sort of grab bag of any adverse event that made you get escalated care and longer hospitalization, different treatment. That's what the SAE was. So I think it's possible, yes, that if we had enrolled twice as many patients, then yes, we may have seen some of those other important findings. And maybe if we had a do-over and did a DOR approach or different sort of ordinal things, then that would have an impact also.
So the conclusion was that among preterm infants with inguinal hernia, late repair had a lower probability of at least one serious adverse event, less days in the hospital in the 10-month observation period, and a greater probability of hernia resolution without repair. The most common serious adverse event in the early repair group was related to anesthesia. These findings are consistent with the pilot study that was previously talked about and the 2022 meta-analysis. The benefit of late repair was greatest in infants younger than 28 weeks gestational age and in those with bronchopulmonary dysplasia. And these were the strengths and limitations that were previously talked about. And then this is the other secondary outcome that is still being done, which is the neurodevelopmental outcomes at 2 years corrected age using the Bailey third edition.
A pretty impressive study by Dr. Blakely, presenting a pilot study on the same topic and being put on stakes for that, and then convincing surgeons at 39 centers to again do the study is certainly commendable. Dr. Rysavy, do you want to, having 2020 vision now and this approach, like what's the future in this inguinal hernia repair? Did the study completely answer the question that late inguinal hernia is safe, or that the future trialist in the audience should design another study with a better outcome, another expensive study with more defined outcome and accounting for loss of follow-ups and things like that?
No study answers all the questions, like Dr. Blakely said. I think, it's an extraordinary undertaking, and it's been, I think, a huge boon to our field to help understand, hey, at least in the aggregate, looking at a composite outcome. And, with some of the discussions that we've had about who was in the trial. So not for the baby who is going to have a procedure anyway, not for the family that says, hey, I can't come back for follow-up, due to whatever reasons. For a lot of babies, it seems that this is a very reasonable thing. Also, very interesting, you saw, we didn't talk about this from a stats angle, but the difference between intention to treat and what actually happens. So assigning, hey, let's delay, that's intention to treat, is analyzing by how we assigned. But in reality, some of the babies who were assigned late treatment actually had surgery earlier. And I think that's a really important clinical interpretation point, is that following babies between now and, whenever that presumed late surgery is really important. And those are the kids who had an earlier surgery for whatever reason, because clinically somebody judged that. But even that approach has been judged to be, reasonably safe, again, by the standards that we set for what we call safety here.
So, Dr. Blakely, a question for you. So, after the impressive results of the study, have you seen in surgery field that surgeons have adopted, those who were more pro early repair have started changing their practice, or they are still very hard to convince with this data?
Yeah, so that's my reason for sort of veering off into this new career path of implementation. Because, what happens is we do these trials and then we try to get it published in the best journal possible. And then we high five each other, and then we're designing the next one, right? And then the next one and the next one and the next one. And that's what I'll just say most large research groups do. And over years, they might have 300 trials published, and maybe they've looked at two to look at the impact, something like that. So the answer is we have no idea, right? We have no mechanism that gives us good treatment practice pattern data. So don't know. Very interesting. I have the group at Northwestern has some implementation science expertise and wants to do an implementation research project around this trial, and probably surveys, because one of the things that underlies the trial were two previous AAP surveys of surgeons, that documented that most of the surgeons were repairing the hernias prior to NICU discharge. So, but there's not a, I guess we need like a Vermont Oxford or something that includes surgical treatments. I wouldn't think they do that, include hernia repair, but anyway, I'd love to know. I don't know.
Well, thank you so much, Dr. Blakely and Dr. Rysavy, for such wonderful insights. A great study, and love to see some neonatal surgical randomized controlled trials being done. Any closing comments, Dr. Blakely, for the trainees?
I just wanted to say it was beautifully presented, very elegant, thorough, really nice presentation. I was nervous about when I was going to get like a red X on the consort thing. So thank you for being kind on that. Just one thing is, when you do trials, again, it's about convincing people to give you support to do the trial. Tansei Raju, who some of you guys know, wrote the RFA that funded this trial, and it was all about perinatal safety. And so he was a huge advocate. And the AAP, since this is sort of an AAP related activity we're in happens to be very important for this trial, because I mentioned those 2 AAP surgical section surveys that did give us treatment pattern data, but also the AAP Committee on Fetus and Newborn published 2 sort of really long, large position papers on inguinal hernia repair. And it turns out that one of them was published like a month before we finished the trial. Well, we had finished the trial, but about a month before we submitted it to JAMA. So the point of that is, when you're thinking about what, we all have limited capacity, we have limited time, we're too busy. Whatever it is you study, make sure that it's sort of been highlighted. I mean, I guess this could go both ways, but typically it's better if a lot of people care about what you want to study. So neonatologists care, AAP cares, surgeons care, lots of sort of observational, retrospective things, but no trial. I think you could also take the opposite tact and say, well, this thing has never been studied before, but needs to be studied. So anyway, thank you guys. This is really good.
Yeah. Dr. Rysavy, do you have any closing comments for the trainees?
Yeah, just really a thank you here. Dr. Gorti, you did a great job. And I think it was clear you prepared really well and presented everything really clearly. That's hard. And thanks to you, Dr. Wolf and Dr. Jane, for organizing this. It's a really great service to our community.
Thank you, all of us who attended. The next session is on November 14th on the Minvi trial. And I hope to see all of you again. And thank you, Dr. Gorti, for presenting such an excellent session. I'll see you all next time. Thank you so much.
Thank you, everyone.
You guys.